Hello, everyone. My topic for today is going to be on non-muscle invasive bladder cancer and its management. My name is Kanesh Seevalingam. I'm one of the urologists from University Malaya Medical Center. So just a disclaimer. I did my fellowship in endourology and stone diseases in Western General Hospital, Edinburgh. But during this period of time, I had the privilege with working with Prof. Mariappan, who is actually a key opinion leader on bladder cancer in Europe. So the objectives for today's talk, it's going to be on single dose installation of mitomycin C, re-resection, re-loop URBT. Intravesical therapies would be discussed on a separate talk, and which are the patients that we're going to offer upfront cystectomy and what's new in the horizon. So this is not going to be a medical school final going back to the absolute basics. And there are many talking points when we come to this topic, uh, which could be cytology versus biomarker. Why doing it? Why not doing it? Do you choose one over the other? The sort of imaging that you would actually do when you encounter patients with non-muscle invasive bladder cancer. Is it ultrasound first versus contrasted CT urography and many more? These are all gray areas and great discussion points. So just briefly on voided urine cytology, it is very specific. That's why there is a role for urine cytology in our current practice. It has a specificity of more than 90%, and it's also sensitive for high-grade disease. The disadvantages, though, it has 10% false positive rates, which actually leads someone going on a wild goose chase. And the incidences of primary CIS is actually quite low without overt papillary disease. And this is shown in one of the seminal papers by Edwards in 2006, which is only about 0.3%. And there are many urinary biomarkers in the market, as shown. No one expects you to know the chapter and verse about it, but just having an idea is sufficient. The take-home message here is it's generally more sensitive but less specific than urine cytology. Since we don't have an approved urinary biomarker and we don't have much experience in Malaysia, let me quote something from the UK, which is the ADX bladder, which involves the cell cycle protein, the MCM5. And just for reference, I've actually shown the cost of ADX bladder, which is about 52 pounds as compared to cystoscopy, 244 pounds, and cytology is just 12 quids. So what does the NICE guideline has to say about urinary biomarkers or any adjuvant clinical test? So it is to offer white light guided TURBT with one of the following, which is could be in the form of a photodynamic diagnosis using aminolevulinic acid, narrowband imaging using green and blue light, urine cytology, urine biomarker tests. But the caveat here is NICE does not recommend biomarkers as a replacement for cystoscopy for either diagnosis or follow-up at this point of time. So these are the pictures taken from augmented cystoscopy versus the control that is white light cystoscopy on your far left. And you can see many of these lesions can be easily missed from just white light cystoscopy, hence the recommendation from NICE guidelines. So let's take our first case. So this is a 70-year-old man who presents with visible hematuria. Ultrasound shows a left bladder mass with no hydronephrosis. So the obvious next step in managing this patient is going to be a transurethral resection of bladder tumor. You can see the loop of resectoscope lighting up. And after the TURBT, we often instill single dose intravesical mitomycin C. So this reduces recurrences by 39%. This is relative risk reduction. and it's level 1A evidence by Sylvester, published in 2004. And that translates into 12% of absolute reduction, and the number needed to treat is 8.5, whereby if you give mitomycin C intravesically to 8.5 patient, you could successfully prevent one recurrence. Further meta-analysis by Sylvester in 2016, he showed that these benefits are limited to less than one recurrence per year and EORTC recurrence scores of less than 5. So don't bust the gut to actually feel bad not giving intravesical mitomycin in especially large multifocal tumors, high-grade looking tumors, or if there is worry concerning on the excellence of hemostasis, or if there is any suspicion of bladder perforation. That patient's histology came out as high-grade T1. So how would you manage it? Ideally, we are not going to speak about BCG in this talk because that is going to be covered separately. We are going to talk about patient selection for upfront cystectomies. So before going to that, I think risk stratification is very important to actually group patients into either low, intermediate, or high risk. So in any situation, I think it is important to remember the extremes. So the low risk patients are those with solitary low-grade diseases, and the high-risk ones are any high-grade, any T1, any patients with CRS, recurrent disease, and tumor size more than 5 centimeters. So anything in between falls under the intermediate category. So our patient here, for the sake of discussion, we label him as high-risk non-muscle invasive bladder cancer. The key information that is needed in evaluating the next step in management would be, is the resection complete? Were there presence of carcinoma in situ in the pathology report, presence of muscle, and their involvement? What is the histology, and is there any lymphovascular invasion? If the patient falls under the high-risk category, then he would warrant a re-look resection or a re-TURBT. The indications for re-TURBT was actually popularized by William Herr in his seminal paper in 1999 using 98 patients obtained from community. So, and he found 75% of residual diseases left behind, and there is a 25% risk of upstaging. So the indications are in a high-grade T1 disease, if there is no muscle in the specimen, unless it's a low-grade TA, and if there is any worry that the resection was not complete during the index TURBT. Contraindications would be T1 disease in a diverticulum. We know that diverticulum is devoid of muscle, so by subjecting to a re-resection, you are going to perforate and you're going to cause seeding. And in an elderly, frail patient with multiple competing comorbidities. Why do we resect? I think it's quite obvious. We want to exclude muscle invasive disease. We want to sample the muscle, and we want to take away any residual disease that has not been cleared during the earlier resection. But the question that we would like to actually look at is, does re-resection influence recurrence and progression? And what are the evidences for that? And does it to some extent influence patient selection for upfront cystectomy? So there is a recent meta-analysis by the Italian group that looked into 3,566 patients. I think this is a more controlled study as compared to William Herr's, and they found a residual disease in 61% as compared to 75% from William Herr's paper. and there is an upstaging in 15% and 11% if muscle was present. And is re-resection itself therapeutic? So Divrik in 2010, a small cohort of patients, 210, he included both high-grade and low-grade disease. It did show some improvement in recurrence and progression-free survival, but it did not affect disease-free survival. Gontero in 2015 showed similar reduction in recurrence and progression, but only if no muscle was found in the primary specimen. Cumberbatch in a systematic review did show it had conflicting data, but pre-TURBT had some chances in improving recurrence and progression in T1. So the overall take is that depending on the cohort and depending on the type of study, there is still some benefit by instituting re-resection in patients, and hence that is validated. But how would that affect patient selection in when considering for upfront cystectomy? That would be discussed on the later part of this talk. So let's assume, for the sake of discussion, this patient had negative pathology results on re-resection. What are his options? So the criteria for looking into patients who may benefit from upfront cystectomy is persistence of T1 disease at re-resection, or a high-grade disease T1 with carcinoma in situ, or carcinoma in situ within the prostatic urethra, large multiple tumors, presence of lymphovascular invasion, variant histology, we will speak about that shortly, and T1 disease in a diverticulum. These are the candidates of patients that I would consider for an upfront cystectomy following a multidisciplinary tumor board discussion. So, as I mentioned earlier, what are variant histology? Some of the variant histologies are actually treated similar to conventional urothelial carcinoma, like squamous glandular differentiation, nested variants. And if there is no residual disease in re-TURBT, it can be actually offered intravesical BCG, and they respond similar as per case-matched series. But there are others that upfront cystectomy is actually the only route out, which is the sarcomatoid, plasmacytoid, and the micropapillary group. And the other one is pure squamous adenocarcinoma. So these are a group of patients that would benefit from upfront radical cystectomy. So now looking into what's new in the horizon, we have seen BYD building jumping cars, the U9, and the swimming ones, U8. But during ESCO 2025, they've presented something that is outside the box, a phase 1b/2 clinical trial using oncolytic virus, which is instilled intravesically in patients who were previously treated with BCG, and they are high-risk patients. And the results so far, the interim results, are quite promising. The 6 and the 12-month recurrence-free survival is accounting for 66 to 55%. And notably, one patient who previously failed BCG treatment achieved the longest recurrence-free survival in the study, approaching 2 years. So these are studies that are breaking frontiers. And I think the data should be out in the upcoming years. And with that, I thank you all for your attention, and let's aim for the stars. Thank you.